Okay, guys, I'll get started. Hi, my name is Meghan Wilson. I am a otolaryngologist at Penn State Health in Hershey, Pennsylvania. I do both pediatric otolaryngology as well as pediatric and adult skull-based surgery, which is a little bit of a random combination, and there'll be more of that in the next talk, which is on ped skull-based surgery. But I first became interested in imaging children, kind of thinking about the number of CT scans we order in kids, and people were talking about the risks of radiation exposure and should we get these CT scans and how should we get them. And I realized several years ago that I didn't know a ton about it. So I started looking into it, and this is like my favorite talk to give. I think it's really interesting and a good way to learn about radiation, about things you can do to minimize radiation when you order imaging in children and adults, but this is mainly geared towards children. So I have no disclosures. I'm, of course, not a radiologist and don't know necessarily all the nuances of the physics and things like that they learn, but I think it's really good to learn about this from somebody in your own department because it can be more pertinent to ENT things, and I'll have some ENT studies later in the talk. So the objectives for this talk are to understand the amount and type of radiation received through different imaging studies, to know the data behind current concerns over radiation exposure, understand dose reduction and alternative imaging modalities, and then be familiar with new and upcoming technology that will hopefully alleviate some of these problems in the future. So the beginning, just to go over a little bit of how X-rays were invented. Sir William Crookes invented this Crookes tube, which was not initially designed for X-rays, of course, but he was looking at electronic charge and the movement of electrons. So basically he hooked a vacuum up to an electric source that had a cathode and an anode, and found that the electrons moved from a cathode to an anode, and the more electricity you put into there, the faster they would move. So Sir William Roentgen, which is why X-rays are sometimes called Roentgenograms. That always confused me on the in-service. I don't think I'd ever heard of it till I took the in-service. But way back in 1895, he was playing with this Crookes tube down at the bottom and sparking enough energy into it to produce light. And as he moved things around his workbench, he noticed that sometimes some objects were blocking the light, like metal objects, and other things like paper were not blocking the light. He then accidentally moved his hand in front of it when he was moving these things back and forth, saw the bones of his hand, was shocked, but realized what was going on, and that was the discovery of X-rays. I actually went to a meeting in Stockholm, Sweden, which is where the Nobel Laureate Museum is, and here is his portion of the museum. And this is the X-ray tube he was using. So it's a modification of that Crookes tube. It's a vacuum, it has a cathode and anode, and can be hooked up to receive electric charge. And this is the first X-ray picture that he took of his wife with her wedding ring on as a Christmas present to her when he first discovered X-rays. So what exactly are X-rays? So X-rays in modern technology are produced by heating a copper wire, which is your cathode, that liberates electrons. An electric charge, high voltage, accelerates those electrons towards a metal target, which is typically tungsten, and that collision produces energy, which is liberated as the X-rays. X-rays are part of the light spectrum. So we have in the middle visible light, and X-rays are over here in the ionizing radiation category, meaning they have more energy. So ionizing radiation is just a statement that it's a particle with enough energy to liberate an electron from an atom or molecule that it collides with, most importantly being DNA, which can cause a disruption in DNA and therefore further problems, which we'll talk about. So once the x-rays were invented, they pretty quickly began to be used all the time. So, I mean, this is jumping 100 years from 1895 when he invented x-rays. And this data is getting a little bit old, but it's the best data we have in terms of just the acceleration of imaging. So this is 1980 and this is 2006. The yearly radiation we receive through just being alive and doing our normal things, it was about 3 millisieverts, and we'll go over what a sievert is later, but it's basically a measurement of the amount of radiation your tissues receive. So we went from 3 to almost double, 5.6, and the natural background radiation has stayed the same at about 2.4, and that's things like just the core of the earth is giving off radiation, so there's a natural amount of radiation we're all exposed to every day. But medical imaging is now about 3 millisieverts per year, which used to be the total. And then there's, of course, more consumer products and things like that that are giving us radiation. So we're exposed to a lot more radiation than we used to be. This is another similar graph, 1980 to 2007, and this one just showing the huge increase in medical imaging as a, medical sources as a source of radiation, with CAT scans being about a quarter of the radiation we receive each year. So why we're focusing on children. So number one, children have less dense tissues, so fewer x-rays are needed to have a good x-ray or CT images. The problem is that they have higher cell turnover and are growing, and so any DNA injury has a higher chance of turning into a problem, mostly a tumor. And they of course have a long life expectancy, so there's just a lot more time for a DNA problem to turn into a real problem, a tumor, or something bad. This is a chart that kind of goes over the equivalent dose based on a number of chest x-rays. So for the far right category, if you have one chest x-ray as your baseline, a CT, is the equivalent of 100 to even 800 x-rays. Fluoroscopy, which we have a lot in ENT for swallow studies, can be up to like 3,000 x-rays. So you really want to think about these imaging modalities and how much you need them and how much radiation exposure people are getting from them. So once CT, or helical CT, was invented in the 1990s, which took CT from being a huge ordeal, it took about an hour, to a couple minute scan, then CT started really rapidly increasing in terms of the number that was done. So this is a comparison, again, kind of old, 2005, but from the UK and the USA, and it looks like we're kind of similar, except when you really look at it, this x-axis is different scales. So the US has just had an insane amount of medical imaging, even compared to other countries, which also had a huge rise in imaging. So after they imaged anything and everything, this is an example of x-rays used to see if your shoes fit rather than just seeing if your shoes fit. They started to think about the risks. So when we talk about x-rays and risks, there's two ways to kind of categorize these risks: deterministic effects and stochastic effects. So deterministic effects is radiation-induced cell death. So this is what you have to sort of think about when we're doing therapeutic radiation for cancers, in that a high dose can compromise the function of an organ or tissue, and it has a threshold to be clinically observable. But what we're really talking about today is the stochastic effects, which is damage to genetic material. So the probability, but not the severity, depends on the dose. So the more images you have, the more DNA damage you could have, and therefore the probability of having a problem increases. This is cancers or even developmental changes, and there's no necessary threshold. Even a very tiny amount of radiation, if you have bad luck, can cause a genetic problem. All right, so understanding radiation dosing. So this is obviously hugely complicated, and I when I did a panel on this at one of the meetings, we asked the radiologist to give it, and he gave an incredible amount of information, very interesting to hear about the physics and a lot of stuff they learned, but I feel like that's way too much information. So this is the very pared down version of understanding radiation dosing to kind of pare it down to what would be applicable for us to remember and use. So a little bit of terminology. A gray, I feel like, is what we often hear about in terms of radiation dosing. That's really just a standard international unit of the absorbed dose of radiation, which has this definition of 1 joule of energy per absorbed kilogram of matter. But what's really used in actually assessing how much radiation we're getting from images is the sievert, which is the basis of equivalent dose and effective dose. So not that you have to necessarily remember these terms, but there's the equivalent dose is the absorbed dose, like a gray, multiplied by a radiation weighting factor. So I have more of this on the next slide, but there's photon radiation, neutron, proton, a lot of different radiation, and they all affect the tissues differently. So that's the equivalent dose. The effective dose is the sum of the equivalent doses to different tissues, each multiplied by a tissue weighting factor. So we know things like the thyroid is more radiosensitive versus something else, the skin. And so you know that the effective dose can be different for different tissues. This is the radiation weighting factor. So again, you have X-rays, you have neutron radiation, proton radiation, all the way up to nuclear fission products. So the main thing we're going to come back to, which is important to take from this chart, is so these weighting factors, and X-ray is 1. Nuclear fission products is 20 times the amount of tissue absorption, basically, versus an X-ray. So a lot of the data that's going to look at why we think imaging is potentially harmful comes out of atomic bomb data, and that's a way different type of radiation. So we'll get back to that. This is the weighting factor for different tissues, and there's a lot of numbers, certainly nothing to remember, but just again to mention that different tissues take up radiation differently and are more radiosensitive to that radiation. And this will come into play a little bit again. We'll talk about it in a few slides somewhere when you're ordering CTs, if you don't need to cover different organs that are more radiosensitive, to leave them out of your study. So people were ordering all their CT scans and sort of thinking about the risks, but it really came to light in 2001 when this article was on the front page of the USA Today as like the main article. And the first line says, each year about 1.6 million children in the US get CT scans to their head or abdomen, and about 15,000 of them will die. So that really sparks attention. And this came out of one study, this David Brenner at Columbia. And I'll go over his study. So this is a paper that came out the day before that article in 2001. It's been referenced more than 2,000 times. So regardless of what we think about it and whether it's correct, it's really out there. It used mathematical modeling. So the objective of this study was to estimate the attributable lifetime risk per unit dose of radiation. I have their results in the next slide, but basically the limitations of this study is that they estimated, again, from atomic bomb survivors. So they literally extrapolated back to small doses based on the amount of radiation received from atomic bombs. So they have really good data in Japan about the distance you were from when the bombs went off, and therefore how much radiation you would have received. And then they've studied these people and known how many of them got tumors and what kind of tumors. So they took that data and extrapolated it back to much smaller doses consistent with what you get from a CT scan. So this is again, just a mathematical modeling study. It has nothing to do with patients. So we have no idea of the dose of a given CT scan. They're just broadly saying that a CT scan would be about this much radiation. And then they took the estimated organ doses for adult CT scans and scaled them back to children. So they're not even really using what children got. So it's a lot of confusing assumptions and mathematical things, which may or may not actually translate to real people. So this is what they showed, and similar graphs will come up again because this sort of thing has been repeated. But basically, you have the age at which you got a CT scan, and this is your estimated risk of dying after that CT scan from cancer. So the important things, and what is real, is that much younger ages, you're getting a higher risk of dying or injury from the scans. And a lot of that will go back to dose. We'll have that in a later slide. But abdominal scans have been linked to lymphoma, mainly because of radiation to your pelvic bones, which house a lot of your bone marrow. And then head scans have been linked to brain tumors. And these risks kind of taper off. The abdominal scans a little bit later, but somewhere around 15 or so, your risk of brain cancer goes down, and somewhere around 30, your risk of leukemia goes down from a scan. And that again goes back to when you're young, you have higher cell turnover, and then just the length of your life is longer for a cancer to appear. So their conclusions are actually not as bad as the USA Today article makes it out to be, which is not surprising. The media likes to hype things up. So their conclusions was that the risk is not negligible, and that their words were actually children might ultimately die. That was left out of the news article. And they conclude, though, as one of the last lines in their study, that the risk-benefit balance is still strongly tilted towards benefit. They were just hoping that their data will improve dose reduction for children. But it definitely sparked off way more than that. So we'll go over a little bit of the origins of data. It's been, of course, like we just said, studied by mathematical modeling. The initial information was really about the mass radiation exposure to the environment. There are some retrospective analysis of previously imaged children. And then what we're not really going to go over today is analysis of children with therapeutic irradiation. So we know that therapeutic irradiation, which is a much higher dose, does make you more likely to have cancers. So that certainly shows you that ionizing radiation can cause cancers, but again, hard to tell whether the normal CT scans and x-rays and things like that will cause problems. So this is a very long-term, well-done, huge study about the people that were exposed to the atomic bombs. And so it's called the Lifespan Study. And they have 95,000 people from the bomb areas and then 26,000 people from other areas as controls. So some limitations, they didn't start this project till about 5 years after the bombing, and tumor data was actually not collected until 13 years later. So some of that was retrospective, but overall, a huge study that's given a lot of information about our risks for when you're exposed to something like a bomb. The first solid tumors were reported about 10 years after the bombs. The excess relative risk is what they use. So this is the relative risk that's excess above the normal risk of receiving a cancer. So that they found increased linearly with radiation dose. So your excess relative risk was 40 to 50 times higher per gray exposed. It's hard to exactly say what a gray is in terms of exposure, because again, we measure our CT scans in millisieverts, and so it's very hard to really understand. Again, this is the problem with a lot of this data. exactly how this equilibrates, but a gray is a lot of radiation. And so they found that this excess relative risk continued to increase throughout life. Again, the more replications of your DNA you have, the more the increased possibility of having another mutation, which then causes it to become significant. And they found a much higher risk in childhood exposure. So for each younger decade you are, such as going from your 30s to your 20s to your 10s to less than 10, you have about a 30% increased risk. And they found this to be the excess relative risk to be significant all the way down to about 0.1 to 0.2 gray, which is still higher than what you receive through like your average CT scan. Again, hard to quantify this, but that is still higher. And they found that lower doses were uncertain. And again, they started estimating this with mathematical modeling, which makes a lot of assumptions. We're having a lot of discussions on modeling. This is very apt, I guess, with the current COVID crisis. And we know that models can be designed to show just about anything you want. So this is the excess relative risk for different types of cancers through that lifespan study cohort. So again, this is based on BOM data, not imaging data, but just interesting to see. Thyroid is right here in the middle. Bladder cancer is actually the most, the most problematic, and oral cavity is in here, but the average for all these tumors was 0.5 excess relative risk. Leukemia incidence peaked at 6 to 8 years post-event. For children under 10, exposure to 1 gray resulted in excess relative risk of 70 at its peak, and then later, about 20 years later, went down to 1 to 3. So for those that were over 30, that excess relative risk peaked at 2. So it's just to show you that the young children have such an increased risk. Their excess relative risk peaked at 70 versus a 30-year-old's peaked at 2. Limitations to this data. So exposures are estimated. This is kind of what I was saying earlier. So they know that if you're 1 kilometer from the Hiroshima explosion, that you got about 7 grays of radiation. 1 kilometer from the Nagasaki explosion, you got 10 grays. And then they extrapolated that back further and further away you are. As I said already, exposure is very different. So the initial radiation emitted is from short-lived radionucleotides like gamma rays and neutrons, and these nuclear fission products, and all of that is a lot different than a traditional X-ray. This is getting into what I think is actually the best studies. So this was a review of multiple cohort studies. So there were studies done in Great Britain, Australia, Taiwan, and Germany that all have national health systems, where they looked at, gigantic amount of data. These are the size of these studies. This one's 10 million, a couple in the 100,000s. This one is the smallest at 44,000. But basically took their health system data and looked at kids who had imaging, and then kids who had brain tumor, CNS tumors, or leukemia, and tried to link the two to determine the risk increase. These, so this is not necessarily pairing one child with a CT to leukemia necessarily, or like the number of scans they've had to a leukemia or brain tumor, but it's just like a huge database study that links the two together. So they used various different risk estimates, so that's not necessarily important, but the ones I highlighted in yellow are the ones that were statistically significant. So the Australian study that was 10 million people found increased risk in leukemia and brain tumors. And the Great Britain one also found increase in both. This Taiwanese study that was still very large, 100,000, showed only the brain tumor to be significant, not the leukemia. And this German study of 44,000, which is small, but still, smaller, but still huge, showed no significant increase in either. So there's definitely some link, is my opinion, looking at studies like this, and that does make sense. Like, again, there's a small probability that you have the horrible luck of that ionizing radiation causing a significant change to your DNA that becomes a problem. But these risks are very low. Like 1.08 is the bottom of this confidence interval. They're all in the 1 times to a little bit 2 risk. So I think there's definitely some risk, but I think it has to be very small, based on you need like almost 200,000 or 10 million people to show a real significant effect. This is going back to similar to that graph we saw before. So the top, this is for head CT and abdominal CT, is the amount of radiation received by your organs. And then this is your lifetime attributable risk of death from cancer. And again, so most pertinent for us are these orange lines, the brain tumors, the amount through head CTs. And a brain tumor risk when you're very young is very high. Sorry, I'm looking at the wrong graph. Very high. And for those, leukemia risk is very low, because again, that's more of a problem when you are hitting your more bone marrow sources. But very similar to what was found in the other studies, which is somewhere around 15, this starts to plateau in terms of the dose you receive and your risk of cancer. So not that we can just order scans like crazy on people older than 15, but just to be in mind that children who are less than 15, you really need to minimize the amount of radiation they receive. So there's a lot of data. This was only part of it. This was originally a longer talk that I've given that had even much more data, but not to bore you, because I think that was enough. There's data on both sides. There's more data showing harm that comes again from atomic bomb data and mathematical modeling, which is questionable, as well as retrospective and database cohort studies that are showing harm. There's also, as we saw, some retrospective studies, database studies, cohort studies that show no harm, and there's plenty of editorials of people upset about this and showing no harm. So you can decide which side you want to be on, but I liked this quote from one paper, that terrifying assumptions have easy success. So when that article appeared in 2001 on the USA Today front page saying 1,500 children are going to die each year from the scans that they received, you can't get away from that, and you got to do something. So the US actually did a really great job, mostly through the radiology societies, of addressing these concerns very quickly. So in 2001, that's the same year as the article, they came out with the Image Gently campaign, and you'll see that. And that is not a rigid plan, and it doesn't say you have to do something one way or another, but it's advocating for the best practices in medical radiation utilization and safety. They wanted to work with governmental agencies and basically develop better estimates of pediatric dosing and better guidelines for the reduction of radiation. This was complemented by the adult campaign Image Wisely that they set off as well. So ALARA is the kind of coined term for all this, which is as low as reasonably achievable. So you want to have the lowest dose possible that will still give you a useful study. In 2010, the FDA put out an initiative to reduce unnecessary radiation exposure from medical imaging, which was just like a more formal document that, again, is not like hard and fast rules, but just guidelines for decreasing radiation and saying things like you should go back periodically and check the amount of radiation that particularly children have received through scans. So all these initiatives basically wanted to reduce variations in pediatric CT imaging techniques. There's not as much anymore, it seems, but I'll go over some of the research. There was still, until very recently, and possibly even still going on today, that when children are imaged, mainly at adult hospitals, they'd be receiving adult doses rather than having really configured, tailored settings for pediatrics. I think a lot of this has improved with just the advancement of technology, and a lot of this, again, I have this later, but a lot of this is just automated into the CT machines, and once they put in a child's or any person's weight and size, that it's going to adjust the amount of radiation they receive. And a lot of this has been educational campaigns. So if you go to that Image Gently website, there's a huge amount of information for patients to read, and basically just advocating that patients know how many scans they've received, so that that can be part of the discussion. It never tells patients to like refuse scans. It wants to educate physicians to ensure proper studies are ordered, and educate industry to improve technology and continue education, and basically establish a common language of the goals for dose reduction and amount of radiation we should receive. So are we doing better? Well, I did a study a while ago that I pulled data from back to 2000, but I looked farther back than 2000, but really there's not much data on dose reduction or anything about radiation concerns in children. 2001, again, was when that USA Today article came out. 2011, obviously the 10-year anniversary, there was a ton of studies looking at like 10 years later, where have we come? But the blue is studies, the red is reviews. Obviously there's a lot more reviews than there are studies, but there's, you know, a huge amount of studies that have been taken to either look at the amount of dose children were receiving, to look at dose reduction protocols and the quality of those studies, or to look at alternative imaging modality. This is a lot, but basically the blue are the USA studies, and all these other colors are other countries. So just to show that the USA has been very much on top of this throughout the years with tons and tons of research. Now, of course, I just searched English language articles, so there could be others in other languages from other countries, but the USA has been the main workhorse in looking at all of these dose reduction parameters. This is from 2006 on, the different subspecialty or specialties that were doing the research. So orange is ENT. So there's been a few in ENT. There's a sinus one I'll talk about later, and a few ultrasound ones. But cardiology has done a huge amount of research because of all the radiation through the fluoroscopy with cardiac casts, and the ER has done a good bit of research too. That's in blue. So just a couple articles. Basically looking at alternative imaging modalities, and how those have changed since 2001. So this is a database study, Pediatric Health Initiative database, that has 33 tertiary care pediatric hospitals in it, looking at data from 2004 to 2012. This is the overall number. So CT is in blue, showing a steady decline in the amount of CT used and a steady increase in the amount of ultrasounds used. MRIs have been pretty stable, but this is good. We've done less CTs and more ultrasounds. These are separated for different indications for imaging. So, you know, there's things like a shunt procedure, shunt problem, that there's still a ton of CTs ordered and that hasn't really changed, but there's not really another way to look at it against severe head trauma. If you have something like head trauma, you want to know if you have an internal bleed, so you might need your CT scan, same with concussion. But the ENT ones, so upper respiratory infections weren't getting a lot of CTs to begin with. It's been kind of stable. Other ENT conditions, again, a little bit of decline, but similar. I would say a lot of this must be temporal bone and sinus scans, which again, you can't really use an ultrasound for that. So we're kind of stuck using CTs for that still. This was an interesting study that was done in 2015, looking at CT scans and intraoperative navigation, sinus CT scans and intraoperative navigation. So their premise was that they were getting upset that when people came with a sinus scan and then needed surgery, that they had to get another scan, and that was excess radiation. So they came up with a plan in their hospital. I won't necessarily say where this is, but they came up with a plan in their hospital that basically there was no longer a regular CT and a stealth CT, or whatever everybody calls their navigation scans, that there was just one CT scan that was able to be used for navigation. So obviously a higher dose scan. They looked at over 6,000 scans in their study period, which is 2010 to 2014. This is an adult study, I didn't say that, but an adult study. And so this is their data. So they're showing that non-ENTs ordered this excess amount of scans when only this amount actually basically needed surgery, because they were using navigation scans for every surgery. Whereas sinus surgeons, and ENT surgeons were doing a little bit better, and their ratio was different. So basically they were advocating for this single modality scan, which would be able to be used for navigation, to minimize these number of scans that were repeated. Whereas what they did not mention in their study is 86% of patients that had a sinus scan did not have surgery. So 86% of people would have just had increased radiation exposure through having this finer cut scan. So you have to be really careful when you're thinking about dose reduction and make sure that your ideas are going to work out, because I think this was done with the best of intentions, but really you're just overall giving more people more radiation. Looking at dose reduction, so this is a very simplified guide. I love this picture. We have two dogs that work in the children's hospital, one on the floor and one works exclusively in radiation. This is Kaya. She will lay down on a CT scan bed and imitate how to lay very still so the children don't get scared and know how to do it. And she obviously doesn't get a real scan, but they'll send her in and out of the machine to imitate a scan. So there's a lot of ways to get kids to cooperate better with scans so that you can get a good scan the first time. So basically, again, the simplified version, the options to decrease radiation are dose reduction protocols. I'll go over that a little bit. Obviously, ordering fewer studies is less radiation, and then choosing different imaging modalities. So dose reduction, again, this is certainly not to totally remember, but there's two ways you get radiation, and that is your tube voltage and current. So your voltage is increased energy, and that will go through denser tissues. So you need more voltage to go through bone than soft tissue, and that is set at one level for each scan. So if you have a big person, you need more voltage than a little person, and that's adjusted to size and body area of the patient. So the tube current is the photons per second, and that can actually be adjusted throughout the scan as needed. And I have a picture of that on the next slide. That can reduce dose up to 40%. And so that is actually, as I was saying, like a lot of this is just automated into machines. So for the voltage, once you put in the age, it's going to calculate your voltage. For the current, it knows based on that scout scan and just the area that you're scanning as to how much it needs for different areas. So I can't find one of these for the head and neck, but just to give you an idea. So this is the current changing this line throughout the scan. So, things like the shoulder with more bone, you need a higher current to get through it, versus once you get to the abdomen and it's a lot of soft tissues, you need less current. So that is adjusted through the scan to decrease the amount of radiation. And as I said on the last slide, that can be a 40% reduction, as opposed to having to do this whole scan up here because you need to get through the shoulder there. The main things that we can do as surgeons or physicians of any kind to minimize radiation is section thickness and scan length. So scan length is just the amount you're scanning. And this comes into play a lot with a lot of our cancer patients. You know, they have a sinus tumor, but you also want to see the neck, or a sinus tumor or skull-based tumors, so you also want to see the brain. And if you order a head CT and a sinus CT, you've gotten two scans that have a little bit of overlap, versus if you say, you know, a sinus CT and, you know, put in the notes extend to the top of the head, that's going to be a little less dose just because you're not overlapping. Also, if you know you only need, it comes up a lot in like airway imaging. If you want a neck scan and you just need to extend to the carina, you can tell them that, because once they take the scout scan, they can adjust the length of the scan. Rather than doing a full chest scan, they just scan to the carina. So there's a lot of options on scan length if you work with your radiologist and put and tell them exactly what you need. You can sometimes decrease the length of the scan, and therefore the radiation section thickness is another huge one. So if you want 1 millimeter cuts versus the normal 3 millimeter cuts, that's about 3 times the amount of radiation. So really only order those thin cuts if you need them. This is a little bit of how we're getting to dose reduction from a technology standpoint. So the way images are smoothed out is through this iterative model reconstruction, and it's incredibly complicated, but basically a computer system does this now. And it takes basically a grainy scan to a smoothed out scan through some, you know, technical averaging and different things like that. So basically it's allowing you to do less dose and therefore get a grainier scan, but still get something we want to look at. And this is the iterative reconstruction technique applied to sinus scans. So these people looked at CT scans, sinus CT scans in patients of varying dose. So these patients were actually exposed to excess imaging radiation because they had multiple scans. But they did the scans at various dose, and then looked to see if they could identify different structures, including like the lamina propria. They also had the anterior ethmoidal artery, and sorry, my mouse got stuck. Okay, so this is showing the lamina propria. So this is the ultra low dose all up to a standard dose over here. And you can see that this is much clearer than this. But do you need all this is the question. So at this one, you can definitely still see the lamina propria. At this one, it is a little hazier, but you can see it better, easier to see it without the arrow over here. Whereas this one, you're really kind of losing it. So their conclusion was that this very low dose scan was adequate for the vast majority of cases. The next thing is fewer studies. So a good first exam is the best dose reduction. You never want to have to repeat an exam, and this is a real problem with kids. So this kid came to my office for noisy breathing, and on scan, it looks like they had 2 tracheas. So this is the negative part of that iterative model reconstruction, is it can smooth out anything. So this kid moved, and somehow, you know, I don't even know exactly how this happened, but now they have 2 tracheas on their scan, and they probably don't. So now you're stuck with like what to do. And ultimately, after talking to mom and listening to the kid and just doing a regular flexible scope in the office, concluded she did not have any real problems, so we didn't have to do anything. But this almost leaves you to the point of needing another scan in a lot of cases to further evaluate the airway. This is a newborn I saw for a nasopharyngeal mass. He had teratoma, splitting his soft palate, and we were going to take him to the OR at about 5 days old to resect it. And I really wanted to know if his carotids were covered. And this is the scan I get. And this is an intubated patient. Like, there's zero reason why they could not position this patient. So some of it is, if you have a scan you really want, it's always good to develop relationships with your radiology colleagues, and again, put in instructions, although you would never think you need to put instructions to make sure the head is straight. Luckily, there's a lot of things, again, they can do with computers, and they were able to reconstruct these images and even it out so that you had a normal appearing symmetric scan. So if you ever get one of these scans that is just crazy, definitely talk to radiology before ordering another scan, because they can do a lot of things to get you better images. And lastly, choose a different imaging modality. So at this point now, you're choosing the better of two evils. So you say, like, okay, great. CTs cause radiation. I don't need a CT. I'll order MRI. Well, children usually need sedation for an MRI because it takes so long and it's loud and they're not going to sit still for that long. So we have this new thing the FDA came out with a few years ago. This was 2016, that anesthesia can harm the brains of children under 3. So now you have people concerned about anesthetics. I don't have time to go into all this, but basically the info is, like, if they have an hour of anesthesia 3 times before the age of 3, it was linked to neurobehavioral problems. Whether or not that's true is even more questionable than the CT data, whether or not it's true, because, you know, children that have surgery more often, more likely to have a lot more comorbidities and other problems. But regardless, we now have this on the internet as well. So I definitely more often, I think, get questioned about anesthesia risks than imaging risks when I'm talking to families. So regardless, you do have options of MRI, ultrasound, and then just further clinical evaluation. So don't have time to talk about all these. There are a good number of studies in the head and neck about using ultrasound for infections. So a lot of these are actually out of, well, this one's ENT, but there's a lot in the ER literature about using ultrasound in the evaluation of peritonsillar infections. I mean, firstly, you don't even really need imaging for peritonsillar infections, but if you can set up something with your ER to either use ultrasound or call you first and not do any scans, that could be great reduction in radiation to not give CT scans for peritonsillar abscesses. We're doing a current study right now looking at ultrasound for lateral neck abscesses, because I don't know about where all you guys are, but in residency fellowship and now there's a lot of CT scans done for little kids with neck abscesses, like lymphadenitis, neck abscesses. And I just, you know, it's great. It makes it very clear cut what they have, where it is, how big it is, but do you really need it? And a lot of people are questioning, like, oh, well, I want to know where the vessels are. And it's like, well, you really shouldn't injure vessels in a simple IND of the neck. So I think currently that's our biggest problem with kids and imaging that ENT could correct, is using less CT scans for lateral neck abscesses. Oh, well, and this is a huge one too. So fees versus video fluoroscopic swallow studies. So again, fluoroscopy has a huge amount of radiation, and a lot of these kids that are getting swallow studies are the neonates, infants, the young kids with swallowing problems. And so that is a small body getting a lot of radiation. And a lot of studies have been done on fees showing that there's no significant difference in the assessment of a lot of different things. Basically just saying that fees is equivalent to a fluoroscopic swallowing study in diagnosing aspiration penetration and all these other problems. So definitely something worth developing a fees program in your hospital if you have the ability to do so. Okay, this last section is the future of imaging. This is a new MRI machine, which it is coming out soon, if not out, but it's not widely spread in hospitals yet. So hopefully will be soon. And basically the special thing about this MRI machine is that it has this silent scan technology. This is GE's system. I don't have any, there's no disclosures. I have nothing to do with this, but I just think it's cool. So their goal is to humanize the MR experience, which will certainly help kids, but also help a lot of our adults. So currently, a standard MRI machine operates at about 108 decibels, which is more than a jackhammer, and it is loud. I've had an MRI. And so you can't like have a baby, babies will fall asleep and could sleep for an hour, but they're never going to sleep in something above a jackhammer going in their ear. This is the silent scan technology, which is per what they have, very similar to ambient noise. Now, ambient noise could mean a whole bunch of things. It's certainly not silent, but much quieter. The other, like, even bigger thing is that they're changing the way scans are done. So this is called a MAGIC scan. So the conventional scans, the reason an MRI takes so long is that all of these sequences, the T1, the T2, the axial, the coronal, all of these things are individually scanned. Like a CT scan, they go through once and the computer does the axial, coronal, all of that. Of course, if you give contrast and not contrast, that's two different scans. But for MRI, like each of these are scanned separately, which just is why a lot of them take an hour. Whereas this MAGIC scan is, again, increasing the computer technology so that you do one 5-minute scan and get all of these 6 images, whereas that was traditionally taking 15 minutes in the past. So that's amazing because a lot of people can sit still for 5 minutes, whereas 15, and really it takes longer, is a lot more for people to sit still. So that's awesome and could help us get a lot more MRI scans. This is the ultimate goal of MRI, which would be amazing. So these are MRI machines. This is definitely not available now. It's a laboratory thing, but will hopefully be available at some point in the future. So the problem with imaging through MRI bone is that MRI is based on the spin of protons, and the bone protons will spin but very quickly fall out of phase again, so you can never get good imaging on bone and MRI, and you have to have like an extremely fast scanner. So as scanners get faster and faster, we'll eventually be able to capture bone, and if we can get images like this from an MRI machine, and especially if we can get them quickly because this is a fast scanner and they're improving that technology as well, then there really will be, hopefully eventually, no need for a CT scan at all. So that would be amazing. And that is it. So hopefully that was helpful in learning like a little bit about why we're concerned about radiation in terms of counseling patients. It's good to have that information, a little bit about at least what we can do for dose reduction, getting the right scan, minimizing section fine cut scans when we don't need them, or minimizing the area of the scan you're covering, and a little bit about what is coming up in the future. So let me get out of here, and if there's any questions, let me know.
Thank you, Megan. That was in depth. I have never heard it quite that in depth before. That was impressive. So, for our audience out there, anybody have any questions regarding Dr. Wilson's talk there? If you can, put them in either the chat or the Q&A function. We'll try and go over those. It definitely gives us more ammunition when we talk to parents, particularly with kids, about radiation doses and stuff, because those questions come up so much more frequently now than they did just a few years ago.
Yeah, exactly. I know you never want to be like, well, I know it's bad, so at least there's something to go off on.
So we had a comment from Mr. Ellison that said, that was great, thank you. I agree with that
You're
comment.
welcome. Yeah, it's kind of a random topic, but it's fun to go over something different.
No, absolutely.
Awesome.
Looks like no other questions right now. So tell you what, why don't we, let's see, it looks like it's 4 till the hour. So grab a big drink of water or something, get your voice ready again, because you're going for a double header here.
Yeah, perfect. Thanks.
So, all right, for those listening, we'll be back in about 4 minutes now. Okay, and Dr. Wilson will do her second talk this morning. So see you just in a couple minutes.